Prescription drug abuse. Did you know that most drug overdoses are caused by the medications your doctor has prescribed you? Do you know which ones those are? Coming up now on Toronto Speaks Addiction. Hi, I'm Dr. Vera Tarman, and welcome to Toronto Speaks Addiction. Tonight, we're discussing prescription drug abuse. What medications are we prescribing that are causing more overdoses than heroin? Is there a safer way to treat chronic pain, anxiety, and insomnia? Joining me tonight is Dr. Kumar Gupta, a Toronto coroner who has seen the devastation caused by prescription drug abuse. He also works in a treatment center for clients who are addicted to narcotics and sleeping pills, the most widely abused of the prescriptions. We are both here to answer your questions about prescription drugs and their potential abuse. Whether you're the one taking the meds or worried about someone who might be abusing theirs, please give us a call. So, Dr. Gupta, first of all, I understand that you are a coroner as well, a Toronto investigative coroner. Can you tell us what that is and how that fits into our conversation today?
First of all, thank you for having me on my show, Vera, and I'm a big fan of yours.
Oh, thank you.
So I appreciate you inviting me today. What a coroner is we are in the death investigation business, where we investigate unexplained sudden deaths at home. So they're non-natural deaths. They're either suicides, they're homicides, or they're accidental deaths. And it is unbelievable how many accidental deaths are due to drug overdoses. It's actually outstanding. And, you know, it's clear that we have, you know, based on looking at the worldwide data of what we do, that we actually have an epidemic of prescription drug abuse in Ontario.
So drug overdoses now, I mentioned in the lead up there that it's prescriptions even more than things like heroin or the illegal drugs.
Absolutely.
Can you
it's
talk
taking
about
over. I mean, we have a system in place in Ontario where physicians are prescribing medications, pain medications such as OxyContin, such as fentanyl, Percocets, benzodiazepines like Valium, Restoril, Ativan. I'm sure the public has heard of those drugs. But the problem is that, you know, the physicians obviously want to help people, but the people that they're prescribing to, some of them end up being addicted, and the physician gets stuck because they're not able to differentiate who's addicted and who's not. Suddenly the amount of medications is going up, the amount of prescribing is going up, and before they know it, the physician has suddenly got them hooked. And now the physician feels stuck. And you know, it's a lot easier for the physician to continue the prescription medications, even though he may know the patient has a problem, than to say, you know what, we've got to get off this. There's a problem here, we've got to taper off. And I think the problem really dwells in the fact that, you know, doctors aren't trained in prescribing pain medications. We're trained in looking at diseases, managing diseases, but we don't have a lot of agendas in medical school and in our training on how to treat pain. And then we don't have a lot of training into how addictive these medications are.
Right, how addictive they are.
Absolutely.
Yeah.
I mean, people will tell you when they get prescribed OxyContin for the first time, what people don't know is as addictive as heroin. When they take their first dose of OxyContin for a prolonged period of time, even if they don't have that addictive personality, you can become physically dependent on them. And then it becomes a rapid cycle into sometimes addiction. Suddenly they're taking the OxyContin not just for the hip pain they had when they fell, suddenly they're thinking, oh, this really works for my sleep.
Well, how does the patient know if they're actually moving into the territory of something that's addictive, and or like addiction as opposed to pain medication? And how does the doctor know that they've got now a problem in their hands, an addiction problem?
Well, I think the telltale signs for a physician are the classic, I lost my script, or the early refills, or the stolen medications. I mean, the reality is no one loses their Ventolin puffers, no one loses their aspirin, but suddenly everyone loses their OxyContin or fentanyl patches, right? So that should be a telltale sign. But the patient who's taking the medications, the ones that are addicted are very good at getting their prescription medications. They're pros at knowing exactly what to say to the doctor to continue that script going. And then what happens is the physician gets fooled in thinking that they're a chronic pain patient.
Yes.
But often what happens is that those pain medications go to the streets, and then they get hooked. Who gets hooked?
And that's where the overdoses occur, is it not? It's the people who normally would not take those medications
Absolutely.
who are taking them recreationally.
Absolutely.
Yeah.
I had I did a death recently of a 16-year-old boy who was a top honor student class, top athlete. He injured his ankle, and suddenly a friend of his offered him some OxyContin. And before he knows it, his behavior's completely changed at home. And when I got called to that residence, he was found dead in bed by the mother. And right before he went to bed, she just heard a really loud snoring noise. And snoring is the pathognomic sign of an overdose. So often when I go to a death of a young person who's died from an overdose, the family will remember this loud snore. It's a little bit loud, maybe I'll just leave him alone, maybe he's really, really tired, and then suddenly they find him unresponsive in bed. And then, you see these prescription medications around the room, and it's always the same story with the families, because it is a devastating illness.
Yeah, and are those medications their own, or some that they got from their friends?
I think some from their own, from the prescription medications from the doctor, some from their friends.
Right.
And you see drug paraphernalia in the room. Typically they're using it not the way it was prescribed.
Right.
Now they're snorting it because it's a better high. Now there's needles in the room, there's foil, they're smoking it, there's a spoon in the room. So it starts innocently. No one sort of, grows up planning to be an addict.
Yeah.
It really starts with a cycle, and always usually starts the same story. It begins with pain.
Yes.
They get introduced to it.
Yes.
And then it just leads down a path that's devastating, not only for the person that dies, but for the families.
But why does that path, why is that such a typical story?
Opiates are unique because when you take opiates for a prolonged period of time, it changes the brain. People don't understand it's not a behavioral problem, opiate addiction. It is a brain disease. So when you take opiates for a prolonged period of time, your brain neurons get wired to opiates. People that are addicted to opiates, every morning when they get up, the first thing they think about is getting their opiate.
And that's even somebody who wasn't an addict beforehand. This can happen.
Wasn't an addict beforehand.
Right. But are there some people where it's more likely to happen than other people?
Well, there's genetic predisposition, as you know.
Yeah.
There's genetic predisposition in families, but I'll tell you that the families that I'm dealing with and the deaths that I've investigated are people that grew up in normal households. Addicts are good people.
Right.
They grew up in good families, good morals, did well in school. They're not the guy hiding in the alleyway trying to steal your purse, what we see on TV.
Yes.
They're our neighbors, they're our friends, they're the people we look up to when we're growing up, and then suddenly they get this spiral.
Yes.
And I don't think they even knew what hit them.
Yes.
It does change the brain. It creates an opiate withdrawal feeling where they do not feel normal without the opiate. And then it becomes more, I just have to get out of bed.
Yes.
I need that opiate to get out of bed, to function, to get to school, and they'll do whatever it takes.
And do they even know that that's starting to happen?
I think they know inherently, but there's a shame factor.
Yes.
Because what happens is when you become truly addicted, you come from a good household, you're a great guy, you don't want to be telling people that you love and people that trusted you,
you probably don't
I'm
want to
an
tell your
addict.
doctor, because your doctor might stop giving it to you.
You don't want to tell your doctor you're an addict,
Yeah.
because he's going to stop the meds. So suddenly you become a closet addict, where everything's great, you look fine, and it's those people that you start seeing signs, the money going missing, because the prescriptions are running out, so now they're buying it from the streets. Now the bank accounts are being drained. They're taking out their child's allowance. They're doing things they never imagined doing before, because addiction is a devastating illness.
Yeah, okay.
And it affects not only the person, like I said, but any family member that's watching the show today who has a child that's addicted.
I'm just going to have to cut you off. Audience, if there's anybody here who can relate to this and wants to ask a question, please do. We will be right back after the break with more help on Toronto Speaks Addiction. Welcome back to Toronto Speaks Addiction. I'm Dr. Vera Tarman, and joining me today is Dr. Kumar Gupta. Today we're discussing prescription medications and the safest way to prescribe them. Dr. Kumar, one of the things that you mentioned was how devastating this is, not just to the addict, but to the family. And by the way, any family members or people who are not sure about their addictions, I encourage you to phone in because you've got some great advice that we can give you. Anyway, would you like to talk about the family side of it?
It's it's the same story for the families. They see a change in the behaviors. They're not sure what quite is going on. They finally realize there's an addiction going on. And, all the families give me the same story of fear. Fear that their son or child or daughter is going to overdose and die. And, it becomes a daily fear. And it actually keeps the families hostage. They don't know actually how to enjoy themselves because they're wondering where their child is. Or are they going to come home stoned? Are they going to come home for a couple of days, go missing? We got incarcerations, people going to jail over currently, breaking the law. So, whenever I do a death at home, I talk to families and I tell them I'm so sorry about your loss, but, they always tell me kind of the same thing as, they lost a child years ago.
Yeah.
Because when the addiction hit, it changed them to such a degree that it really just, they were almost like expecting it. And I'll tell you, some families are almost relieved. Very sadly, almost relieved that their fear is now over because they knew that was going to happen. They knew the overdose was going to happen.
It's a daily fear.
It's a daily fear. It's almost like they felt it finally happened. And it's a terrible thing to say, but it's how they feel.
Well, now you mentioned that sometimes the family is taken hostage, and because there is the real fear of death. I mean, I think it must be one of the #1 causes of death for people under the age of 30. So oftentimes, in my experience, what we see is that the family will give money, they'll pay the rent for somebody, they'll do anything that they can because they're afraid that they're going to get the news from you.
Absolutely.
Do you have any suggestions about what to do for the family in this kind of a context?
It's really easy to say, get out, get help, leave the household, and don't come back until you're better.
Yes.
And that's an easy route. But I find that route, in my experience, typically leads to worsening addiction. Because now it leads to street drugs. They're living in shelters where the addiction is very high.
Yes.
And, the family, the success stories,
yes.
That we see death, but we also see success stories is when the family sticks around, helps them get into treatment, goes to the appointment where the doctor says, he has a trouble with this drug,
yes.
help him.
Yes.
They're actively involved, and you've seen, we see some terrible deaths, but we've also seen some wonderful success stories with families being completely involved.
Right. So you would not be an advocate of the sort of tough love approach?
Until you have someone in your family that you have that addicted,
yes.
and I can't speak for the families, but I find that for what I've seen, sometimes the tough love leads to suicides. They don't have a place to stay.
Right.
They have no one to call.
Yeah.
It's a cycle. I call it the shame cycle. You have such shame in what you become. Every addict has a good part to them, right? They just feel really bad about themselves to the point that, when you feel so down and bad, what are you going to do? You don't go to church and pray to God. You use more drugs. You use more drugs, numb that pain, and it becomes a vicious cycle into full-blown addiction. So I often find that when families reject people, it actually leads to worsening cycles.
Okay.
And again, sometimes tough love does help. Incarceration, as you know, they end up in jail because they stole something. Suddenly they see the light.
Yes.
They end up overdosed.
Yes.
And now they really are afraid.
Yes.
And they end up going to an inpatient treatment program or
yes.
detox.
We have a caller. Eva's on the line. Eva, do you want to ask Dr. Kumar Gupta a question?
I do. Hi, Dr. Tarman.
Hi.
This is actually, either one of you could ask. I'm inquiring about the opiate addicts who are currently on a methadone or Suboxone treatment and have upcoming major surgeries. Obviously, there would be opiates administered if the surgery is major enough. Are there alternatives that are available to these types of patients after major surgeries, or should they just, under supervision, be administering? Sometimes they get the morphine drip and are allowed to administer that drip themselves. I mean, I find that amazing, but is there an alternative?
That's a great question. Thank you, Eva. So let's look at that. Is there an alternative? But also, can you also address the fact that if a person is on a program, does taking that drug potentially re-stimulate their addiction? So I'm going to give you both of those.
Well, in my experience with people with acute pain, if they broke an arm, for example, and they're going to a surgery for a broken hip, I don't think giving them pain medication is going to trigger more of an addiction. I think that what it does is if you don't give a person with addiction enough pain medications, they're going to use more from the streets which they don't want to go to. They don't want to call their drug dealer to supply the medications. They expect their doctor to treat their pain similar to a non-addicted patient. And again, it's not so much what they get at the time of the surgery, it's how long it's prescribed after the surgery. So again, it's always length of time.
Right.
And bear in mind that someone with addiction is going to want those medications for a longer time than someone without addiction. So whoever's prescribing should be well aware.
Should the prescriber try to find an alternative, or like, what's your take on that?
I don't think there's much alternative if you broke an arm, and it's quite painful. If you have surgery, you're going to get an opiate. I don't think an anti-inflammatory is going to help someone with major abdominal surgery,
yes, right,
or hip surgery. I mean, I think the key is we agree that an opiate should be administered.
But what about the dentist? Now, I can't tell you how many times I get somebody who's on a program of some sort, like Suboxone or not Suboxone, but methadone, who has had a tooth pulled and they've got 30 Percocet prescription.
Yeah.
And I'm thinking, I wouldn't have taken that. Why does this person?
Because they're very good at getting their medications, Vera. They're very good at saying, I remember my perks, I remember the days when I was addicted. And that brings back to the caller's question, which she's concerned about the fact that, if people get those medications, it'll trigger a behavior. So, again, the best person to prescribe medications, pain medications, to someone on methadone, which is your question, are the actual methadone prescribers. Because they're the addiction specialists.
And they know how long it should be.
And they also know how to dispense it.
Okay.
Because a typical doctor will give a month and say, here it is, like the 30 perks.
Exactly.
A methadone doctor will say, you know what? You're going to get 3 Percocets a day with your methadone, daily dispensed to the pharmacy.
Right.
Now that's a safer way, because the tendency of an addict is to overuse.
Okay, so that's a way that you can prescribe the medication but control the amount.
Absolutely.
So that they won't overdose or sell their drugs.
And the reality is family doctors don't know that. Family doctors never daily dispense or weekly dispense their meds.
Yes.
They give a whole bunch.
Yes.
And when I deal with the deaths, it's not so much, it's how it was dispensed. It's a multiple medications that are prescribed to the patient in abundance.
Yes.
And that is overused in abundance.
Yes, that's right.
And so it is the controlled dispensing that's key to someone with addiction. And you're helping the addiction by doing it controlled. The person truly in recovery will appreciate controlled dispensing.
Okay. Now there's another point that Eva didn't ask, but it begs the question. We know as physicians that the more you prescribe opiates, you get you get more hypersensitive to pain.
Right.
So how can we avoid? The person may well need more medications than your regular person.
Absolutely. It's funny you say that. They did a study, and the study is that the higher amount of opiates you go to, sometimes pain actually gets worse. Sometimes when you go too high, actually it does a paradoxical effect of pain.
Yes.
And so they actually found that, and most doctors don't know this, most doctors think they can address 100% of the pain with opiates. But in fact, no matter what dose you get to, they did a study really that only 30% of your pain is being addressed. But the patient expects 100%. And until the physician makes it clear, look, I can only treat and address 30% of your pain, then at least there's no expectation to keep on going up and up and up.
Yes, yes,
right?
yes. Just for any of the callers, if you have any questions about your medication, or you know somebody who's on medication and you're worried about that, you're wanting to know maybe something that you're relating to, please give us a call about that. Okay, now you mentioned that people are really good at getting medication. So how can you tell give me some examples.
Well, we have a system in Toronto, unfortunately, where currently, I can go, if I'm an addict, to Yonge Street Walk-in Clinic and get 30 Percocets for dental pain, for example.
Yes.
On that same day, I can go to York Mills, go to another walk-in clinic, limp in the office and say, I strained my knee, could I get 30 Percocets? Then go downtown again to another walk-in clinic and get a fentanyl patch for back pain. And we have a system where we have nothing in check. So in fact, 3 different prescription narcotics can be filled out in Toronto on the same day
By the same
by the
person.
same patient,
Yes.
by 3 different doctors. None of the doctors will know that they
Yes.
both all gave the medications, and none of the pharmacies will know. And that's the system we have in Toronto. In Vancouver, we have what we call a triplicate prescription. That would be impossible. Are we moving forward in Toronto?
Yes.
Now there's a movement towards that,
Yes.
slowly.
Yes.
A bit too slow, though.
Yes.
Knowing what we know about how devastating this illness is.
Yes.
And then we have the person who's getting the medications. Addicts are really good at getting their medications. And doctors are overworked, they're tired.
Yes.
Sometimes, the reality is sometimes doctors know that this patient is probably addicted. But you know, when you have a waiting room full of 80 people, and you got this guy, how do you best get him out of your office?
That's right.
Give him your 30 perks and have a good day and hope
get
you
him
never
to
see him
promise
again.
that he'll never come back
But he will
again.
come back.
Yeah.
And he'll come back in a week. And then suddenly you're trapped with an ongoing prescription. And
Yes.
that's the reality of addiction in Toronto. And again, doctors are not very good.
Is it okay for the family, if they have a child, to call and say, look, my son is a patient of yours and we're worried about it? Like, are you legitimately allowed to talk to the family? Are you able to have that kind of conversation?
I don't think I'm allowed to talk to them because of the confidentiality issues, but I think the
Yes.
phone call is helpful.
Yes.
So the phone calls help to the doctor from a family member saying, look, my son is hooked on these.
Yes.
What you don't know is that he gets his prescription from you that day and he uses it all in that day. What you don't know is he's buying
Yes.
it from the streets, snorting your medications,
Yes.
and has overdosed 3 times in the emergency room. That's what you don't know.
Okay.
So when a family doctor hears that from a family member,
Yes.
they obviously know there's a problem now.
Yes.
Because the patient who's an addict will never tell them that,
Right. Right.
the true signs of addiction.
So that would be like for the family who might be watching, that might be
Absolutely.
something that they know that they can do. And I'm just wondering, are there other things? I mean, we know that there's a prescription drug overdose. Pardon me, a prescription drug.
It's an epidemic.
There's an epidemic.
Yeah.
Yeah. Do you want to? Why is that the case?
Well, it's an epidemic because, you know, we, again, like I said, doctors are very good at helping people. They're not very well trained at saying no to narcotics. And they're not very well trained in when to stop. And then the cycle leads to a lot of abundance of medications
Yes.
going in the wrong hands that leads to the public and leading to innocent people that were never addicted, who never had pain,
Yes.
suddenly getting hooked.
Right.
So it becomes an epidemic, and I think the system that I described, a system where we can have double doctoring
Yes.
in Ontario without any checks or balances.
And I mean, there's outside of just the fact that people can actually get medications fairly easily in the way that
Very
you've
easy.
described, there's also the whole aspect that especially with young people, like 2/3 of where they're getting the medication is from their family medicine cabinet.
Absolutely.
Or their friend's medicine cabinet, or their friend's family who's saying,
Yeah.
here, have some of this. Now, you, Dr. Gupta, are actually made quite a revolutionary precaution a number of years ago with methadone, where you insisted that people have locked boxes.
Oh, you remember that?
I certainly do, and you were the one that introduced that to the methadone doctors. What do you think about that as like having a locked prescription cabinet upstairs in your bathroom?
I think it's a fantastic idea. I think that the problem is I don't think the families are well knowledgeable about how addicted these medications are. And
Even
are probably
their
a little,
Tylenol ones, probably.
absolutely.
Yeah.
They're a little naive.
Yeah.
And I think
Yeah.
that when you get a prescription narcotic,
Yeah.
you got to lock it up.
Yeah.
Because
Okay.
someone's going to die.
We have a caller. Jane, would you like to ask a question to Dr. Kumar Gupta?
Yes. Hi, Dr. Tarman.
Hi, Jane.
Hi, Dr. Gupta.
Hi there.
Hi. I am an alcoholic and an opiate addict.
Okay.
And I've been in recovery for a year and a half. And now I have a good program. I'm in 12-step recovery. And I have a strong faith in a higher power. Anyway, I have spinal stenosis. And I've heard you talking about doctors freely giving out opiates. I have the opposite problem. My doctor is very against any type of opiate. And my spinal stenosis is quite debilitating. My pain doctor, I go to the Center for Pain Management. She recommends that I be on tramadol. My family doctor absolutely refuses to prescribe tramadol. And I'm just wondering, is tramadol an anti-inflammatory or an opiate or both?
Jane, that's a great question to ask because a lot of people are really confused about the drug tramadol. So, Dr. Gupta, if you could address that and also just the whole dilemma of what does a pain...
First of all, congratulations on your recovery. And, it speaks to the fact that there is a problem in Ontario, but there are people, people with addiction, like the caller, deserve pain control. Everybody, no matter whether you're addicted or non-addicted, everyone deserves pain control. And if that pain control has to be an opiate, then so be it. But it has to be someone well trained in giving some people in recovery, the proper opiate to do a sort of recovery program with opiate management. And, in this situation, they're all scared of her because of the addiction.
That's right.
And they're afraid that it's going to lead to the streets.
So they may, in fact, not want to give it to her.
Absolutely.
Yeah.
I think in your case, tramadol is an opiate. It's a very weak opiate. What it does, it stimulates your internal endorphins, very similar to Toradol in that category. But it is considered a Class A drug. It is considered a narcotic. It is one of the weaker narcotics. And you're absolutely right that I feel for you because if you have a lot of pain and everything else is failed, like the nerve blocks, like anti-inflammatories, I know you probably tried them all, then you should get a trial of a narcotic. But I think what happens is it's the level of discomfort of doctors, and again, it gets down to education.
Yes.
Some doctors are just not educated in that, but you should keep looking around.
So should Jane get help from an addictions doctor to make sure that she's taking them in a way that won't re-trigger her?
I think she'd
or
have
is
probably...
a pain medication doctor good enough?
Well, I think if the pain management doctor has enough comfort in treating her and giving her in a controlled fashion with a narcotic contract in place, then that should be a contract where there's no overuse, they're weekly dispensed, no early refills will be dispensed, then that should be completely fine. I think it's really just finding a doctor who's willing to do that.
Great, thank you very much. I hope, Jane, that was helpful. We have another caller, Cindy. Cindy, would you like to give us your question, please?
Yes, hi.
Hi, Cindy.
I have been on it's out now Oxy-Neo and Oxycocet for about 15 years, but I've had numerous operations, 2 back surgeries with steel, and I've tried the nerve blocks, and I end up just being on this, and I've sought counseling, but you are stuck in a catch-21 because luckily for me, I know other people that have take these strong medications and they go up and up and up, where I have seemed to stay on the same level.
Well,
but is there anything else out there that I can reach out to? I'm kind of stay at home a lot, so I'm not aware of what's totally out there. And I guess that would be my question. Where do I find other pain? Is there anything else out there that I could tap into?
You mean in terms of other medications or other resources?
Yes, resources.
But it's your dilemma that are you comfortable on your medications? Are you doing well?
Yes.
Well,
but I can't. Am I going to have to be on these for the rest of my life?
That's a good question. I think that sometimes what some patients do is attempt to wean off the medications.
Yeah.
Slowly wean off and see how their level of functioning is. Sometimes when you're on an opiate for a long time, you don't know where your pain's at. You lose a sense of your pain because you're on opiates. And so only when you get off opiates, you really know where your pain's at.
Because you might find that you don't actually need them anymore.
Absolutely. And it's funny, when we detox people off opiates inside a treatment program, some people have 2 things happen. Either you have worse pain and you need an opiate, But miraculously, a lot of people actually have less pain. And they actually feel better off the opiate. They're more energy, they're less tired, they're happier.
Yeah.
You know, a lot of opiates can cause depression.
Yes.
And so, you know, I think the trial of a taper is probably the best bet with your doctor, and then going to alternatives, like you want maybe a weaker opiate, maybe. But I would talk to your family doctor about that.
Yeah.
Yes, because I do suffer from depression and big-time anxiety.
Right.
Right, and so the medications could actually be contributing to that as well. Okay, so did that answer your question, Cindy?
Yes, it does.
Okay, thank you very
Thanks,
much
Cindy.
for calling in. Okay, so I'm interested in more precautions that people can take. So particularly about the family, people who might be watching. So you mentioned that there's the, you might want to urge the person, if they have to take meds, that they're on a contract, that we lock up the prescription cabinet in some sort of way. Anything else that might be helpful?
Well, I think families, when they see a child or their family members on narcotics, they should probably get more involved in their treatment. So they start seeing this narcotic medication that's new to this person, coming every week, and now every month, and now it's like another year, then maybe it's worthwhile for them to go to the office visit with them. Because they may be seeing a different type of behavior at home that the family doctor may not be aware of. So I think family involvement is really critical. Now remember, someone addicted will not want their family member to come with them to the doctor's office, because a big Pandora's box does not want to get open sometimes. So I think that it's really the proactive approach, and the families being questioning, why are you still on this?
Okay. Now, if a person decides, maybe somebody's watching, thinking, maybe I am addicted to this, what, or, you know, I would like to get off, maybe even Cindy, I don't know, would like to get off, what would they do?
Well, I think that the telltale signs of someone who's addicted are the classic ones. When you have a fight with your spouse and you're popping a Percocet because it makes you feel better, then you may have some addiction. If you're overusing it because you like that buzz feeling, you have more energy, then that's addiction. If you're taking it for stress in the workplace or getting on the bus because you feel more relaxed, then you're truly hooked. And it will never lead into a good place. It will lead to more and more drugs and a diminished bank account.
And more drugs of that, like, it's not like you can, I mean, for some reason Cindy doesn't seem to need more, but usually the story is the person, if they're taking it for that, they need more.
Cindy is a perfect patient. Cindy's been on the same amount, never increased, and actually thinking of wanting to get off that.
That's unusual.
That's a perfect patient, and that's she's not obviously addicted. And then there's the other person was on 20 Percocets a week, and now is on 100 Percocets a week a year later. Then that's a problem.
Now, what does that person do if they decide it's time? I got to do something.
Well, there are many options, but one is telling your doctor. Now, that's likely not going to happen because there's a fear factor getting cut off.
Getting cut off.
There are facilities.
How often does that happen?
Many times.
And
you know, I'll tell you, the people that get completely cut off their prescriptions end up being sometimes suicides to my end. You know, these are people that are devastated. That they can't cope with withdrawal. Opiate withdrawal, we haven't talked about this, is a very, very serious side effect of opiate addiction. And it is the most horrible experience someone could ever describe to you. It's like a huge, large toothache all over your body. They can't get comfortable. They feel absolutely horrific. They feel terrible anxiety.
Can't sleep.
Horrible sweats. They look terribly sick. And when you get to that state, until you get to that state, when you look at the behaviors around an opiate addiction and not getting opiates, like stealing where they never imagined stealing, draining their bank accounts where they can never imagine doing that, it's a real reality of opiate addiction, opiate withdrawal. And you know, there are detoxes where there are medications where addiction doctors like us can help people get off nicely, and there are great medications to get off opiates. And you know, it's funny that you and I hear the same stories when they enter our treatment program. If only I'd done this earlier. You know, it's not as hard with the medical supervision. That's the answer to your question. Medical supervised detoxes are the way to go. And they're not as horrible as people suspect they are. But it's a fear. The fear of withdrawal is what drives the addiction. It's a fear of withdrawal, the fear of that horrible feeling I described, that prevents people from going to the detox, and they'd rather just it's easier to, go on the streets and spend all your money and get your 10 Percocets and you're good for another day.
Right, yeah.
You know.
Yeah, and they may well be afraid to tell, or because they're just,
Absolutely.
they
The
just
cycle
get
of
cut off.
shame.
Yeah.
The cycle of shame.
Yeah. Now, if one of the things that we often recommend is either Suboxone or methadone, either
Absolutely.
short-term or long-term,
Yeah.
and then one of the rebuttals that people will often give is, but that's just another drug.
I know.
So what do you say to that?
It is, they are last resort medications. I think people should try the medical detox first, but I think that there are many people that have true pain phenomena where they have no other choice but to get on another opiate. And then, yes, they are hooked, but it's kind of like the good witch and bad witch from the Wizard of Oz. It's still a witch because you're dependent on it, but it takes you in a different direction.
So you're saying using the methadone for pain instead?
Absolutely.
Yeah.
Using the methadone or Suboxone for pain takes you in a direction where you're not going to the streets.
Yes.
You're getting it legally from a doctor in a controlled dispensing pattern, because Suboxone and methadone are daily dispensed to the pharmacy initially.
Yes.
Where they have to leave urine drug screens and show that they're sober and abstinent.
Yes.
And people who are part of that program, and again, we're not pushing that to everybody,
Yes.
but people that get methadone and Suboxone will talk about a true recovery and good pain management, and it's really a way to go, just because of how serious opiate withdrawal can be.
So what's your experience about the success of people getting off of methadone or Suboxone as a route, as a bridge to getting off of their opiate over?
I mean, it's not a lifelong medication except for a few people, and some people want to taper off methadone and Suboxone when they're finally off, and some people do it with their doctor. They have a good relationship with their doctor.
Yes.
But I think it's after many years of sobriety. It's after getting away from all the high-risk people, changing your cell phone number so all the drug dealers that used to call you can no longer call you.
Yes.
And it's really a sort of a time factor. But the relapse rate for opiate addiction, as you know, is about 90%.
Is really high.
It's really as high as smoking cessation.
Yeah.
If
If there's anybody who has any concerns about their medication, or maybe perhaps that they would like to know what to do because they're thinking there might be a problem, please give us a call and hear what we might have to suggest to help you. Okay, great. That's really good, Kumar. Thank you. What about other medications? So we've been talking a lot about opiates. What about benzodiazepines, sleeping pills?
Well, sleeping pills are a real problem, and when we do the deaths in Ontario for mixed drug overdoses, benzodiazepines usually show up somewhere.
Okay.
It's always part of the equation.
So we're talking about clonazepam,
Valiums, Ativan.
Yeah, and those are so widely prescribed.
Widely prescribed.
Yes.
Starts with poor sleep. It starts with anxiety disorder, and benzodiazepine addiction can be actually more serious than opiate addiction.
Okay.
Because it's very hard to stop, and if people who are truly addicted to benzos could have a serious seizure if they stop, if they get too heavily into it. And so I think it's the same phenomenon of talking to your doctor about tapering the medications. There are many alternatives to benzodiazepines that maybe the patient doesn't know about or the physician wasn't aware of.
Yes.
Such as other non-addictive sedatives.
Yeah. Yeah, but it's been my experience that with the public press, we're more and more aware of, fentanyl and OxyContin, but I still see people with, Ativan prescribed liberally, really liberally.
It's a real problem.
So you're saying that that's a big issue with overdoses?
It's a huge issue. When we look at the toxicology results of many of the people that die in Ontario, you'll see a mixture of benzos and opiates and sometimes alcohol. So it becomes kind of a mixed phenomena.
Yes.
And the reason why they're dangerous in combination, they're central nervous system depressants.
Yes.
So typically the patient will take the opiate, take the benzodiazepines.
May not even know
they
it's
don't know,
dangerous.
but it depresses their nervous system, so they go to sleep.
Yes.
And they actually find that their respiratory system is now being depressed and end up having heart failure and respiratory failure and then die in their sleep.
Yeah. I've had people come to me and they're alcoholics. They've given their benzodiazepines to get off of to detox, and they're doing a self detox, which I'm always going, how is that possible?
Right.
That the doctor just said, here, you can try to figure this out yourself.
Right.
And then they end up doing both and bad.
It's a bad mix. And that's why detox is so important. I mean, it's a big step for someone to say, I got a problem, go detox. It's a huge step.
Yes.
And, and some detoxes can happen with their doctor, but they have to be trained in doing it, trained in dispensing it properly, know knowing when to say enough benzos,
Yes.
and now it's time to get off the benzos.
Right.
And, you know, we're really good at giving, as you know,
Yes.
but we're not very good at taking away.
Yes.
And so it ends up being that we give, and then it becomes more, and then more, and it's a cycle. And, you know, I think, you know, patients have to get better at educating themselves, but doctors have to get better at knowing when to say no, and knowing
Yeah.
when it's time to sort of say it's time to get off.
Now, I'm going to tell you one of my pet peeves, and that's the emergency
Oh, yeah.
office, or
Right.
even the psychiatrist who's only seeing the person once.
Right.
And thinks nothing of prescribing a prescription of clonazepam,
Yeah.
or the emergency doctor who's giving the 30 Percocets or the 30 Valium for detox.
Right.
And is there anything that we can do about that? I mean, these are not people who have a long-standing relationship.
Yeah.
Yeah.
I think that you know, obviously the psychiatrists, as you know, are very good at giving tranquilizers. Part of their training.
Yes.
That anxiety
Yes.
disorder, you give tranquilizers, and you know, and but what the psychiatrist often doesn't do is screen for addiction. That half of the people entering their office with anxiety are probably hooked to crystal meth, or using cocaine on the side, or
Right.
maybe they're alcoholic, but they're not telling the psychiatrist.
Yes.
You know, addiction's a very closeted phenomena.
Yes.
And until you ask the question, and what doctors aren't very good at saying, are you addicted? But some doctors are actually getting better now.
Yes.
Some doctors are getting smart. They're actually doing urine drug screens in the office for people getting who getting
Right.
pain medications, then finding cocaine, finding other medications, saying, wait a minute,
Yeah.
I think this guy may have a problem.
Yeah.
And then referring them to a methadone program appropriately.
Yes.
You know, I think that it really depends on the level of education. So awareness from both the doctor's end
Yes.
and the patient's end.
And we have to have a standard of practice where we do
Absolutely.
that, because that hasn't been the case. The
Yeah.
standard has been just to write the prescription and, you know, out the door you go. Yeah.
And I think it's an overburdened system. Healthcare is an overburdened system where, you know, when you see a patient who's, you know, it takes two hands to clap. The patient is doing everything they can to get that Ativan.
Yes.
You know, the doctor's a bit afraid now.
Yes.
The patient's like, you know, and getting into withdrawal.
Yes.
And then it's so much easier to give them those 30 Ativan and never see them again, than to say, you know what, I can't do that.
Yeah. Now, one of the things that I've experienced is that people will say, okay, there's a problem, but then there's a shortage of help available. I mean,
Right.
unless you can afford to go into
Yeah.
one of these more expensive places,
Yeah.
you're relying on CAMH, or you're relying on
you're right, Vera, I mean,
Salvation
absolutely.
Army, or the emergency ward, which
Right.
they want you out the door as quickly as possible.
I mean, we got 30,000 family doctors or 30,000 practitioners in Ontario.
Yeah.
But only maybe 300, 400 of us are addiction doctors
Yes.
that truly understand the devastation of the disease. So
Yes.
you're right, there's not a lot of doctors who do addiction medicine.
Yes.
Who are very aware
Yes.
of how to treat it or how devastating it is.
Yeah, that's right. Or how to taper somebody
How
safely.
to taper it.
Exactly.
Absolutely.
Yeah. We have a caller, Lisa. Lisa, do you want to give us your question, please?
Yes, hi. My question is, I've been listening to your show right now, and I've been addicted to oxycodone for a year, but actually opiates probably since my 20s, since I had my wisdom teeth pulled out.
There's the dentist story.
Yeah, the dentist, and then actually morphine, because I had an early pregnancy, and they tried to withhold. It was in the 80s.
Oh, yes.
I was like 26 weeks early, and for a week they had me on a morphine drip. And anyway, throughout my life I've struggled with depression due to this opiate use now that I realized on and off. But I was addicted to the oxycodone a year ago. I was up to taking about 14 a day.
Right.
And now I wean myself off. I'm down to 4 a day.
Are you doing that weaning yourself?
Yes, I am.
Okay, go ahead.
But and I've also told my doctor about it. She does not prescribe the oxys to me.
Okay.
I get them myself.
You get them yourself on the street?
I do. Yes.
Okay.
Through somebody who's selling them.
Okay.
Unfortunately, that happens.
Yeah.
And my question is, I'm also on Seroquel at night. Only 50 milligrams, and I heard Dr. Gupta say that it suppresses your nervous system and your breathing. And I guess I'm concerned because I really want to get off totally, but I'm concerned that adding the Seroquel at night Could I overdose?
Yeah.
Okay. So, Lisa, we've just got a little bit of time. Do you want to
Sure.
just start, and we'll have to come
Well,
back?
Lisa's doing amazing work. I mean, the fact that
Yeah.
she's trying to get down. But Lisa, if you're struggling with this for more than a year and you're trying to wean yourself down, I mean,
Yeah.
first of all, congratulations, but maybe seek a program. I don't think you probably need methadone, but I think Suboxone, which is a much weaker opiate, it's much easier to taper off Suboxone
Yes.
than it is off Percocets. And the reality is, when you're doing a self-taper, in my experience, people with addiction who do self-tapers always fail. I've never seen someone succeed. I hope you succeed, but if you want to do it right, and it's a new year, try to get on Suboxone program. As far as the combination effect goes, be careful with the Seroquel. Obviously, the Seroquel is helping you because you don't used to take the Percocets at night to help you sleep. Now you've weaned yourself down. But just be careful and get help, Lisa, and all the best to you.
Lisa, do you have anything more to ask about that? We're going to go for a break in a second. Do you want to hang on?
I'd like to hang on, please.
Okay, well, just hang on then for a second. So
I just have a question. That's okay. Where would I go for help then?
You can Google. There are, most methadone clinics in Ontario now do Suboxone as a first line treatment. So you've heard of methadone programs, I'm sure.
Kumar, we're going to come back to you in a second. We will be right back after this break with more help on Toronto Speaks Addiction. Welcome back to Toronto Speaks Addiction. Today we're discussing and taking your questions on prescription drug abuse. So Dr. Kumar, you were in the middle of answering a question to Lisa, and you were talking about, she was asking about different forms of help, but in the break we were also talking about what do you do with the insomnia and with the anxiety that stops when you stop both opiates or anxiety medication.
Insomnia is a big problem for people trying to get off opiates. And, for Lisa's case, she's trying to wean herself down. I think it's something like Seroquel that's prescribed is appropriate, or Remeron. There's Trazodone. There's all sorts of different agents. It's always a bit worrisome if you're taking a lot of Percocets along with that and combining it. But she's actually trying to get off, and I think that she's just struggling for the last part of it. She was asking a question of Lisa. You were asking, is she on right now?
Yeah, Lisa's still on.
You were asking a question of where do I go? And I think any methadone program will have Suboxone, and Suboxone's a weaker opiate. I don't think you need something as powerful as methadone. Suboxone's a weaker opiate.
And you only need to be on it for a few weeks even.
Yeah, absolutely. Yeah. And you could just get on Suboxone for a few weeks or months.
So she could theoretically get off those 4 or 5 perks.
I think the key is giving control to somebody who knows the Suboxone and has an addiction knowledge, taking the control out of your hands, where then you're forced to go to the pharmacy on a daily basis for a while to do it properly, right? And then wean off properly, safely. That doctor will give you proper medications for your sleep, for your body aches, for your hot flashes.
And the panic attack?
Sorry?
And the panic attack?
Absolutely. There's great medications out there. And I think that the key is you got to get connected with a doctor that understands addiction and all the symptoms that will come out as you're trying to get off the opiate.
Exactly.
And sometimes it takes time. I wouldn't rush off. I would just basically get involved and get engaged in treatment where you're now forced to leave a urine every week, be accountable to a doctor, show clean urines, meaning now you have to stay away from the suppliers in the streets. And once you get the clean urines, that doctor will trust you to get the Suboxone home.
Because that's one of the things. Thanks a lot, Lisa, for your question.
Thank you.
That's one of the things she said there. That was like, to me, a bit of a red flag, actually having to go out and get it herself. So this would get her out of that world into a safer place.
Absolutely.
Yeah.
The biggest problem with addiction is our cell phones. Because it's the cell rings, and then it's like suddenly, the next supply of Percocets come.
Yeah.
And it gives you, time away from the drug dealer, from the people that know your cell phone, that are not good for you. And that sometimes may take several months, right, Lisa? But I think getting connected with the doctor is really important at this point, because you want to get better. I feel you want to get better. I think you need help at the end. So a little bit of surrendering yourself to that would be good.
Now, another question that I have that comes up is, you mentioned about, the crystal meth or some other drug the person's using. What about, we're prescribing opiates abundantly. We're prescribing benzos abundantly.
Right.
What about those stimulants that we're prescribing abundantly, like Ritalin and Adderall? And how much is that contributing to the problem? Because you're taking a speed pill in the morning, and then how do you get to sleep at night unless you take an Ativan or something like that?
So there's this, again, lack of understanding. People are addicted out there. They're abusing the Ritalin. Some are hope using appropriately, and some are. But many are abusing even Wellbutrin, the classic medication for smoking cessation. People have found that it gives them a high similar to cocaine. So they're and it's funny, we've seen a lot of Wellbutrin overdoses at our office.
Really? You can overdose on Wellbutrin?
Absolutely.
There you go. Interesting.
Absolutely.
We have another caller, David. Thanks for calling, David. Why don't you give us your question? Oh, sorry, David. I'll wait for you. Yes, why don't you tell us a little bit more about, so even something as innocuous as Wellbutrin can cause a problem. And I would imagine with another drug on
like you
board.
said, it's a medication that are getting prescribed that we're finding in people's system. Nowadays, mixed drug overdoses. It's not so much heroin. Heroin's passé. It's so much easier to get OxyContin from your nice doctor down the street than it's from heroin from big drug dealer, right?
Okay, David, we are ready for you. Do you want to give us your question? David?
Yes.
Hi there, David. We can hear you.
Good. Yeah, I'm a speaker. If you can't hear me, tell me. Are we good?
Yeah.
Can you, David, can you go off speakerphone and just go directly onto your phone?
Yep, you're off speaker. I'm off speaker.
There, that's much better.
All right. So, the thing is, I was born with a congenital birth defect plus scoliosis of the spine.
Yeah.
I never took any pain meds in my life, nor a Tylenol 1, up until I was mid-30s. So, I never smoked, just casual drinking as kids like we all do, right?
Yeah.
Just normal, but nothing, no drug abuse or anything else. But what I want to fast forward to is now, now in my early 40s, 7 years having been on oxycodone, extended release plus instant release for breakthrough pain.
David, give us your question because we're getting low on time.
The question is, I'm thinking, I understand a lot of people that are abusing these drugs that in my case are life-saving. I'm just wondering if we could maybe somehow put a twist on the positive side of how, when used properly, how they could benefit people like me.
Okay, thank you.
Because generally speaking, just very quickly, the doctors are really, really afraid. I've been tapered down from, 270, 240 mgs a day down to 140.
David, I'm going to let Dr. Gupta answer because I want to make sure he gets the time to do that.
Yes,
David, you actually are completely correct that there is an opiate of fear because of what we see with the abuse. The addicts make it bad for the ones that have legitimate pain, like David. And there are studies that suggest that the elderly population, not that David's elderly, but the old are getting under-medicated with pain medications. And in fact, I've actually done, there's been, people are actually killing themselves because they don't have the proper pain control and relief from. So we're not, the message, and David's absolutely, the message can't be that opiates are bad. Opiates are saving lives and helping a lot of people who need that opiate for chronic pain, such as David, to function normally. And I think that you're right. There's a balance here.
You've got to find that balance.
And he's right again about the opiate fear in physicians who have patients with legitimate pain and are just really afraid to give it.
I mean, we really have to find a way to, you're right, it's either one or it's hot or cold, and we're really stuck, and education is going to be a major factor with that. Kumar, we're just about at the end here. I'd like to say thank you so much for your time coming in to speak. I mean, we've known each other for quite a while, and I'm just really happy to have had the opportunity to get you to come and speak.
Right. Thank you, Vera. I used to consider myself a colleague. Now I'm your fan. So there we go.
Thank you. And just really interesting to hear the investigative coroner side of things. Hearing the part that we don't usually hear about. So we are out of time, and again I'd like to thank our guest, Dr. Kumar Gupta, and I'd like to thank all of you callers. We'll be back next month with more Toronto Speaks Addiction. Thanks for watching.